Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. Welcome back to another episode. Today is just me and you. We are just going to go over all things antihypertensives so that we know what is going to happen on our arterial line blood pressure or our non-invasive blood pressure, depending on what we're monitoring in the operating room when we give these antihypertensives. And when patients come to us on some antihypertensives, what that means for us in the clinical realm within the operating room. So let's dive into it. Don't be too sad that it's just me and you this morning. We're gonna get it handled. So today our learning objectives are to differentiate from beta blockers, calcium channel blockers, our ACE inhibitors, and our ARBs, which we will go into. We want to be able to understand their hemodynamic effects and knowing what to do when your patient takes them chronically. We also want to be able to recognize how they interact with anesthesia and apply that knowledge to our anesthetic plan so that you are prepared for the clinical setting and becoming that certified registered nurse anesthetist or whatever type of anesthesia learner you are. Okay. So the first section we're going to get into is the mechanisms of action. Knowing what these drugs do and how they do it is really important when it comes to doing that risk-benefit analysis on what drug you're going to pick to combat the high blood pressure. Or again, if the patient comes in on it, what's our action plan if we have hypotension because of the medications and antihypertensives this patient may be on, okay? So how these meds work. Once you understand this mechanism of action, things get a lot easier. Let's talk beta blockers first. So we know from undergraduate pharmacology, right, that beta blockers block primarily beta 1 and beta 2, right? That beta 1 is the B1, right? And those are primarily in the heart, right? Sometimes beta 2, which are in the lungs. And it's really important to understand that beta 2 concept, which I'm sure, again, in undergraduate pharmacology, you remember 2 lungs, right? Beta 2. That's how we remember that the lungs are primarily functioning off of beta 2. When you're blocking beta with our beta blockers, as one does, obviously this decreases the heart rate, the contractility. It also decreases renin release, decreases myocardial oxygen demand, which we love in anesthesia. That is the primarily the mechanism of action of our beta blockers. Okay, so when you think about giving the beta blocker, you have to think about how much of that beta blocker affects beta 2. Next is our calcium channel blockers. So there are actually 2 types of our calcium channel blockers, and we'll go into each of these individually later. But our dihydropyridines, which are our amlodipine and our nicardipine. Both of these cause vasodilation. Okay, we love nicardipine. I use it a lot. And for my neuro ICU nurses, you guys are nodding along. And then we have our non-hydropyridines, which are our diltiazem and verapamil. These actually decrease heart rate and decrease contractility. So we have our DHPs, our dihydropyridines, and we have our non-DHPs, our non-dihydropyridines. Okay, those are the 2 classifications of calcium channel blockers. And so in order to remember this a little bit better, the DHPs, which you'll see, DHP CCBs or non-DHP CCBs. For our DHPs, so that would be our amlodipine and nicardipine drugs. These are our smooth muscle relaxers, which is why it has that vasodilation property. And then we have our non-DHP CCBs, which are our beta blocker adjacent because they have that decreased heart rate and decreased contractility component of their mechanism of action, which is really important. Next, we're going to go into our ACE inhibitors. Okay, really important that we understand how ACE inhibitors work. These block the conversion of angiotensin 1 to angiotensin 2. And by doing this, by blocking the conversion of angiotensin 1 to angiotensin 2, we have decreased vasoconstriction, we have decreased aldosterone. Basically, they vasodilate like crazy. The nickname for these are the you guys will kind of go into this later in the lecture, but the vasoplegic syndrome that you see is so real, so true, does occur for our patients that are on ACE inhibitors, which is why the literature is kind of inconclusive on whether or not to actually hold ACE inhibitors, and it depends on a lot of patient factors on that. But in terms of the hypotension, refractory hypotension, which is a good board's key term, that refractory hypotension you will see. And the main treatment for it, and again, we'll go over it again in this lecture multiple times, is, say it with me, vasopressin. That is the treatment, because our phenylephrine and ephedrine work on a completely different system than vasopressin. Vasopressin works on those V1 receptors, whereas the adrenergic receptors are affected by our phenylephrine and ephedrine. So when you're using the adrenergic receptors, they're not going to be responsive. If our patient's on aldosterone or are on ACE inhibitors, rather, it will be responsive to that vasopressin because of the different mechanism of action of vasopressin. Again, really important to understand the actual mechanisms of action of these medications, because it changes our course of treatment for patients to improve patient outcomes. Next are our ARBs, our angiotensin receptor blockers. These block angiotensin 2 receptors directly. So same type of vibe as the ACE inhibitors, but no bradykinin cough. So you'll see these patients, and I'm sure you guys are nodding along that you've seen patients that are allergic to lisinopril, our ACE inhibitor, because they have this dry cough. So basically the ACE inhibitors or the ARBs rather, are the ACE inhibitors without the drama of that side effects. The second section so we went over the mechanism of action of all of our main antihypertensives. We talked about beta blockers, beta 1 being at the heart, beta 2 at the lungs. We talked about our calcium channel blockers and our two types, our DHPs and non-DHPs, and the differences between the two. We talked about our ACE inhibitors, how they work, and the vasoplegic syndrome that comes along with it. And we talked about our ARBs, which are basically ACE inhibitors without all of the dramatic side effects. So now we're going to go into their hemodynamic effects and our anesthetic implications for that. So which drug will tank your blood pressure the fastest on induction? Spoiler alert. ACE inhibitors and ARBs every time. So for beta blockers, hemodynamics you'll see are that decreased heart rate, decreased contractility, mild decrease in blood pressure, right? Because our cardiac output is dependent on heart rate and stroke volume. So you'll have a decrease in cardiac output, mild decrease in blood pressure. It depends on the beta blocker that you are choosing. So some of them are more selective to beta 1, which I want to make it really clear that if you have a beta 1 selective drug, like let's say esmolol or metoprolol, that doesn't mean that their beta 2 properties, are beta 2 blockade properties, are completely null. Nothing is ever 100%. So that's something to really consider. But also these are really important because if you have labetalol, for example, and I may mention this in the lecture again, if you have labetalol, it's a 6-to-1 beta 1 to alpha 1, 6-to-1, mostly beta 1, 6 beta 1 to 1 of alpha 1. So actually it's an alpha and beta blocker. So it has this component of decreasing the heart rate while also causing vasodilation, which is really cool when you're trying to get the heart rate lower, but also decrease the blood pressure at the same time, less selective to that beta 1. So anesthesia implications, blunted response to direct laryngoscopy or laryngoscopy in general, video as well. I've actually read a study, it's been years, about using esmolol instead of narcotics to blunt the response to surgical stimulation. I'm showing that, and it did show that we kind of overuse narcotics when it comes to tachycardia, and maybe we should be leaning more towards short-acting beta blockers like esmolol, for example. So blunted response to hypotension, harder to increase heart rate when needed. A bradycardia more profound with high vagal tone, so pediatrics and spinal anesthesia. So beta blockers, basically we are just slowing that heart rate, as we already know, honestly, from undergrad. But the differences in the different beta blockers that you can choose in the operating room, which are primarily esmolol, are short-acting RBC esterase metabolized medication that's very short-acting. We have metoprolol, which is mostly beta 1 selective, and then we have our labetalol, which is a little bit of both, right? That beta, and has a little bit of alpha property, 6-to-1, and a little bit of vasodilation associated with that decrease of or that blockade of alpha 1 and causing that vasodilation rather. So next, let's talk about our calcium channel blockers. Okay, let's talk about our DHPs. So those are our, again, amlodipine, and nicardipine. The hemodynamics is basically they are potent vasodilators. They have minimal effect on the heart rate. So the implications of this in the operating room are that they can worsen hypotension from our induction agents. Okay. So let's talk about our non-DHP. So our diltiazem and verapamil. So the hemodynamics, these do affect the heart rate. So when you think of the differences between DHP and non-DHP calcium channel blockers, I want you to remember primarily that the non-DHPs do affect the heart rate and the contractility, whereas again, those DHPs just cause vasodilation and have minimal effect on the heart rate. We avoid non-DHPs for patients with severe bradycardia or heart block. That makes sense because it affects that heart rate and contractility, and we don't want to mess with that if they already have severe bradycardia or heart block. We also want to be very wary of using these non-DHPs when combined with beta blockers. Because of that, bradycardia and AV block risk skyrockets when those two medications and those two, honestly, pathways in the heart are impacted by those two medications together. So a little phrase to remember when you're thinking about what medications to not give together, non-DHPs plus a beta blocker would be a situation where you could say, congrats, you just bought yourself atropine, maybe epi, because you have severe bradycardia and potentially an AV block by blocking these two components of contractility in the heart. That's really dramatic, but we are always thinking about worst case scenario, and worst case scenario would be our non-DHPs with the beta blocker, and those non-DHPs are diltiazem and verapamil. Okay, so let's talk about ACE inhibitors now. So our angiotensin converting enzyme inhibitors, the hemodynamics associated with them are its massive vasodilation, decrease in preload, and decrease in afterload. So those are the components of ACE inhibitors that I want you to consider. Decrease preload, decrease afterload and SVR, obviously, with that massive vasodilation. So the implications of this in the operating room, I've touched on it already, but refractory hypotension on induction is so real. All the experienced anesthesia providers are nodding along. We've seen this a lot, and we know that if a patient is on an ACE inhibitor, especially if they've had a prior anesthetic, I'll look at that anesthetic record, and if they got vasopressin the last time, I know to not even mess around with myfavoritelearners and phenylephrine. If I see intraoperative or post-induction hypotension, we'll just go straight to vasopressin, right? May require that vasopressin, and we talked about why that has a different mechanism of action than our most used vasopressors in the operating room. Or high-dose phenylephrine may work. Fluid loading or just administering fluids, stop the morning of surgery. Again, there's mixed evidence on that. Many anesthesia providers will still hold those ACE and ARBs for big cases, but for minor surgeries, it's often continued. Again, it's that patient risk stratification on the ups and downs of giving it. I think they did a big study on it and found that whether or not they held them or not, the patients had the similar outcome. So it wasn't statistically significant enough to honestly go one way or the other. So that is a clinician preference and in terms of guidelines. So if your patient after induction has a blood pressure 60/40 and they're on an ACE inhibitor and they're on that lisinopril, know that vasopressin isn't your future, okay? Giving 0.5, 1 unit at a time to start to see how they do and titrating accordingly after that, depending on how they respond to the vasopressin. Our next set of drugs that we're going to go, or antihypertensives that we're going to go into are our ARBs, our angiotensin receptor blockers. So in terms of hemodynamics, they're very similar to the ACE inhibitors. We basically said that ARBs are the non-dramatic version of our ACE inhibitors. So we're sticking with that in terms of the hemodynamic effects of our ARBs, but they are even more refractory to catecholamines. So again, they often respond better to vasopressin. Those adrenergic receptors are just not as responsive, and vasopressin is going to be your best friend in the scenarios where your patients have refractory hypotension on an ACE or an ARB. So if these ARBs are taken within 24 hours, very unpredictable swings. You may also have hypotension, like I said, that refractory hypotension. Many anesthesia teams hold ARBs preoperatively, especially losartan or valsartan. But again, it is clinician preference at that point and whatever your facility has a protocol to do within your department. Basically, I want you to remember that, again, with ARBs, that phenylephrine may not save you. call for vasopressin, or get it ahead of time, have it ready if you know your patients are on these medications. Better to be prepared in these scenarios with these specific antihypertensives. Better to be prepared with these antihypertensives. Okay, so let's talk about perioperative considerations with these drugs. So what do I do when they took their meds this morning? What do we do? Okay. With beta blockers, we want them to continue the morning of surgery. This is because stopping beta blockers abruptly actually increases your risk of MI. So we want them to continue it, and actually it is a skip measure protocol to do this, to make sure patients receive some type of beta blocker prior to surgery if they are on them chronically. But we are also watching for bradycardia during induction and high spinal if we're doing neuraxial anesthesia. Obviously, these patients have a lower starting heart rate to begin with. For our calcium channel blockers, we want to continue both DHPs and non-DHPs. If they're on diltiazem and metoprolol, have your anticholinergics ready. You may have to give an anticholinergic to increase that heart rate. We talked about giving calcium non-DHP calcium channel blockers with beta blockers, so you may have to support that heart rate with an anticholinergic. And our favorite in the OR is, everybody said, glycopyrrolate. It's a lesser form of atropine, and we love to give glycopyrrolate in the operating room for that reason. We just don't like big commitments in the OR. We like to have short acting because things in the OR are so dynamic that the less of a duration of action, the better for us. So ACE and ARBs, the big question, and I've mentioned it a million times, but general rule supported by many institutions is to hold the ACE and the ARB the morning of major surgery and to continue for minor or ambulatory surgery. What this means is you probably will not see a minor surgery case be canceled because the patient has took their ACE or their ARB. We just go ahead and assume that this patient may have refractory hypotension or consider that they might, and know that we may have to use vasopressin, whether that means grabbing it ahead of time or calling for it if you have staff to assist you with that. But honestly, planning for vasoplegic syndrome, regardless of the scenario. Clues that your patient is at a vasoplegic syndrome risk. Patients that are at risk for this are our elderly patients, our patients that are on chronic ACE or ARB therapy, patients that have a long-standing hypertension, and a high anesthetic sensitivity. So these are our septic patients, our dehydrated patients, or our hypovolemic patients. So all of these patients are just more at risk for having that vasoplegic syndrome after induction or during an anesthetic when they are on those ACE and ARB medications. Lastly, maybe, I don't know how long I'm going to talk about this, but let's talk about interactions with anesthetic agents specifically. So with these antihypertensive medications and our volatile anesthetic agents, which we'll talk about first, basically they have an additive myocardial depression effect with beta blockers and our non-DHP calcium channel blockers. There's an additive vasodilation effect when we are on ACE inhibitors or ARBs in terms of the medications that have an interaction with propofol. They are synergistic hypotension with calcium channel blockers, our ACE inhibitors, and our ARBs, which makes sense. We've talked about synergy at least in other lectures that I've given in my pharmacology classes, but 1 + 1 = 2. It's both together cause that synergy, and you have a bigger risk of hypotension with propofol, calcium channel blockers, propofol and ACE inhibitors, and propofol and ARBs. With propofol and our beta-blocked patients won't mount a reflex tachycardia. So you give propofol and it has that vasodilatory effect and you hear the heart rate go up with that baroreceptor reflex that happens with the vasodilation from propofol. On beta-blocked patients, you will not have a reflex tachycardia. So don't count on it. Don't titrate your anesthetic based on that reflex tachycardia, which I hope you never would, but that is the take-home point for propofol with beta blockers, is they will not have that reflex tachycardia that you normally see. Okay, with ketamine, let's talk about ketamine and our antihypertensives and what impact they have on one another. So ketamine has it's beautiful for patients on beta blockers, but less effective for ACE and ARB hypotension. We don't use in severe CAD unless necessary. So that is a wrap with ketamine and our antihypertensives. With neuraxial anesthesia, so our spinals and epidurals, you will see severe hypotension in patients that are on chronic ACE inhibitors or ARBs, which we've talked about, but you will definitely see that with our neuraxial anesthesia and ACE and ARBs. In terms of beta blockers, you have an increased bradycardia risk with neuraxial anesthesia. So you just know that if your patient is on a beta blocker, they may have an increased bradycardia with onset of an epidural or a spinal. All right, you would basically consider prophylactic vasopressin if refractory after a spinal. All right, applying these concepts to an anesthetic plan, because that's what this is all about. This is all about making clinical connections and understanding how, why do we care? Why do we even care? This is why we care. What do we do with this information? So let's talk about case number 1. It's going to be a patient on metoprolol chronically. So are we going to continue or hold their metoprolol? Everybody said, continue. We want them to take their beta blocker because there's an increased risk of MI for patients who don't on day of surgery. So within 24 hours of their surgery, they need to have taken their beta blocker. And we're also going to expect a lower heart rate range intraoperatively. We are also going to treat bradycardia first with glyco or atropine, most likely glycopyrrolate, and these are our anticholinergics. Maintain an adequate depth of anesthesia. They have a blunted stress response. So again, you don't want to titrate your anesthetic based on the heart rate solely. We want to look at the huge picture of what's going on in the operating room. So what this is basically saying is that just because you don't see tachycardia doesn't mean the patient is not at an adequate depth. So you may still need to have them at that. You do need to have them at that adequate depth of anesthesia, regardless if their heart rate is responsive to surgical stimulation or things like that, because they have that chronic beta blockade on board already. All right, so that was case number 1. Let's talk about case number 2. This is a patient on amlodipine. So amlodipine, we are going to expect vasodilation. We want to gently preload these patients, make sure they are adequately hydrated and have that preload ready to go, because I think about preload being the tank. We want the tank to be adequately full and not aggressive, but preload gently. Going slow with our propofol, and phenylephrine works great here. So this is a scenario where phenylephrine is going to be effective. Whereas this next case, so case number 3, is a patient on lisinopril, which is an ACE inhibitor, correct, or losartan, which is one of our ARBs. So for this patient, what is the main thing you're going to ask them in pre-op? Everybody says, did you take this? Did you take this morning? When's the last time you had your lisinopril or losartan? When's the last time you had your ACE inhibitor or your ARB? And hopefully the patient says, oh, I haven't taken it. They told me not to take it for 24 hours prior to surgery. And you'll be like, perfect. I'm still going to prepare for vasoplegic syndrome because this patient is on these chronically. However, it's less likely to have that vasoplegic syndrome if they haven't taken it within 24 hours of anesthesia onset or induction of anesthesia. But we're still going to prepare for hypotension because it's resistant to that phenylephrine. So we are going to have what medication ready? Vasopressin. I'm hammering this home. If your patient is on an ACE or an ARB, consider vasopressin. Consider vasopressin very heavily. Have it in the back of your mind that if you do not have it in the operating room, that you're going to have to call for it potentially. And some patients have really surprised me and not needed it when I thought that they definitely were, whether or not they had one or more of those risk factors, a septic elderly person, things like that. And it's, again, just patient dependent. You want to preload these patients carefully as well. Consider ketamine or etomidate for induction to decrease the risk of that vasodilation and vasoplegic syndrome potentially. Consider avoiding high dose volatile anesthesia early. Just, start low, go slow, give them what they need without causing profound hypotension that may occur post-induction. Case number 4, a patient on diltiazem and metoprolol. So for this patient, you're going to prepare for bradycardia. We talked about how the diltiazem, that calcium channel blocker, is more susceptible to bradycardia. Avoid large doses of propofol boluses. Avoid high spinal levels. Really being vigilant with our dermatome level post-spinal anesthetic is really important. Having atropine and epinephrine, drawn up or ready to go, or readily available. Consider glycopyrrolate pre-induction. And that is one of those things that as a clinician, you kind of decide whether or not to give. I've talked to a lot of providers about whether or not they, for example, for a patient who's on a beta blocker, whose heart rate's, 50 prior to insufflation of the abdomen, because you can have that vasovagal response to the celiac reflex, where you have that bradycardia that can happen with the vagal nerves being stimulated during insufflation of the abdomen for our pneumoperitoneum and our laparoscopy procedures. And I've talked to a lot of providers on whether or not they pre-treat with glycopyrrolate or not. And I don't. What I do is I communicate with the surgeon really closely and probably kind of annoyingly. And I just say, hey, the heart rate's 50. I'll let you know if it goes any lower and you have to exsufflate. Because if you exsufflate and you stop tugging on those nerves, you will see the heart rate, generally speaking, this is a generalization, not 100%, nothing's ever 100%, but you will see that heart rate recover very quickly. So what I don't want to do is give glycopyrrolate, and then with insufflation, some patients have tachycardia with insufflation, depending on their anesthetic depth and their anesthetic requirement and all of those different things, what's going on physiologically with the patient. And so I don't like to pre-treat because I've had a little bit of tachycardia after insufflation if I've pre-treated with glycopyrrolate. But I know a lot of providers that do pre-treat with glycopyrrolate. So that is a clinician-specific scenario on whether or not you would give glycopyrrolate pre-induction to this fourth case patient that is on diltiazem and metoprolol. So that's provider dependent. So let's summarize this all up. There you have it. We have our beta blockers, our calcium channel blockers, our ACE inhibitors, our ARBs, all in one place with our anesthetic implications that matter when you're dropping an induction or managing a spinal. You don't need to memorize every drug. You need to understand how they change physiology, because anesthesia is physiology with receipts. It will show in your anesthetic what is going on. I'm going to end this podcast with one piece of encouragement or advice with you all, as I do on this podcast. And I know not all of us are overcommunicators. I am a huge overcommunicator, but when you are in the operating room, communicating confidently with your surgeon, with your preceptor, with your circulating staff, knowing their names, all of these things, it's a huge tip for you as an anesthesia learner to learn the names of the people around you, to be able to communicate respectfully and succinctly, because in these scenarios, you're going to have the thick skin and the gumption to stand up and say, hello, Mr. Surgeon, Mrs. Surgeon. Hello, surgeon. You need to exsufflate the abdomen right now because this patient's heart rate is not tolerating. You have to be able to advocate for your patient. You have to be able to communicate in situations that can be really intimidating or scary. You also have to know when to call for help. Somebody bring me vasopressin right now. So being able to increase that confidence, know the people around you, know the level of knowledge of the people around you is key clinically. So I hope that encourages you or reminds you you can do this. You can be confident, be an over-communicator, and bug everybody, because your patient will thank you at the end of the day. So it was a pleasure being with you, my favorite learners, to do a quick little summary of these antihypertensive drugs in anesthesia. If you're in my course, you will hear down to the molecular level of that. And if you want another one where I go down to the molecular level, put it in the comments, like, subscribe, do all the things. It was a pleasure being with you today, and we'll see you next time. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.